Uh, Thank you, Dr. Joyce, for the kind introduction. Dr. Twahir, I hope you're not left for Lamu and you can stop sharing the screen. Thank you. So I'll be speaking today on the cardiorenal continuum of SGLT2 inhibitors. And let me just try and see if I can get the slideshow running. Yeah, so I hope you can see my screen.
Yes, I can. Yes,
okay,
we can.
Excellent. So I'll be talking about the cardiorenal continuum in the era of SGLT2 inhibitors. I would like to thank Dr. Tahir for such a comprehensive talk, and he has mentioned quite a bit of what I was going to elaborate on. Unfortunately, I don't own a plane like Dr. Tahir, so after the conference, I'll still be around in Nairobi. I'm not going to Lamu for a holiday, but I do aim to or aspire to be like my mentor, Dr. Tahir. So going straight into the topic, if you look at diabetes, and this was a slide from the International Diabetes Federation, IDF Atlas, for 2017, we have 10 million more adults with diabetes than in 2015. And we have 34 million more adults who are at risk of developing diabetes than in 2015. And even if you look at the geriatric population, even then there'll be a significant increase in the geriatric population who are above the age of 65 with diabetes than in 2015. And you can see the amount of money that is spent, that is going to be spent in 2017 is going to be 54 billion US dollars more than in 2015. We have quite a significant number of people with diabetes who are undiagnosed, 19 million. 1 in 6 live births is affected by hyperglycemia in pregnancy, and over 1 million children and adolescents have type 1 diabetes. This is a slide again from the IDF 2019, and it was comparing the figures from 2015 to 2019. Worldwide, we can see that there's going to be a whopping 51% increase from 2019 to 2045, from 463 million to 700 million. So you can see that this is going to be a significant burden on the healthcare systems worldwide. Now, if you look at Africa, Africa will have the highest percentage increase as compared to the rest of the world. We'll have a 143% increase from 19 million in 2019 to a projected 47 million in 2045. So even in Africa, we are expecting to see a huge increase in the number of people living with diabetes. And again, this can cripple our healthcare system as well. And remember that these are grossly underreported numbers as well, especially in Africa. So what is the relationship between diabetes and cardiovascular risk? So if you look at it, there is a threefold increased risk of acute coronary syndrome in patients who have type 2 diabetes as compared to the non-diabetic controls. The patients with type 2 diabetes have the occurrence of acute coronary events 15 years earlier as compared to the non-diabetic controls. The diabetic patients have a twofold increased short and long-term mortality. So even if they do survive the acute coronary events, the risk of dying is significantly increased as compared to the non-diabetic controls who actually developed acute coronary syndrome. There is an increased incidence of post-infarction, recurrent ischemic events, heart failure, and cardiogenic shock as compared to the non-diabetic controls. So the type 2 diabetics are basically at a higher risk of developing all the complications of acute coronary syndrome. Now, despite the improvement in terms of the therapeutics, the mortality is still high in patients with type 2 diabetics, and the life expectancy is strongly reduced, as you can see in this pictogram. Patients with diabetes who are more than 60 years, their lifespan is reduced by 6 years. Now, those who are diabetic and had a cardiovascular event, either a myocardial infarction or a stroke, their life expectancy is reduced by 12 years. Diabetes doubles the risk of all vascular events. So if you look at it, it can increase the risk of coronary artery disease. It can increase the risk of death due to coronary artery disease or an unfatal myocardial infarction. It increases the risk of ischemic strokes, hemorrhagic strokes, and the strokes that were not classified, patients died. It can also cause other vascular deaths as well. The risks are much higher in patients with diabetes than in those without diabetes. If you look at it, diabetes can affect all organs. 50 to 80% of people with diabetes die of cardiovascular disease. Almost half of new kidney failure cases are observed in patients with diabetes. If you look at our dialysis units in the country, you'll see that almost half or 3/4 of the patients actually are diabetic. Diabetes is also commonly associated with non-traumatic lower limb amputations. Almost 60% of patients more than 20 years who are diabetic get non-traumatic lower limb amputations. 16% of people aged more than 65 years with diabetes die of stroke, and almost a third of patients with diabetes aged more than 40 have some form of diabetic retinopathy. So there is a significant unmet need that exists to reduce a complication of diabetes. People with type 2 diabetes are also at an increased risk of heart failure, and they have a 2 to 3-fold higher risk of developing heart failure. Now, those patients who have diabetes and heart failure, they have a 60 to 80% greater probability of all-cause mortality and cardiovascular death as compared to those patients who don't have diabetes and heart failure. Now, what is the pathogenesis of diabetes and heart failure? Is it because of coronary artery disease? And the risk of heart failure in diabetes occurs independent of coronary heart disease and hypertension. And it causes a type of a cardiomyopathy called the diabetic cardiomyopathy. And this was initially introduced based upon the post-mortem findings in diabetic adults who had heart failure in the absence of coronary artery disease. So the diabetes, because of its advanced glycation end products, actually causes some form of a cardiomyopathy, which is called the diabetic cardiomyopathy. And this is defined as a ventricular dysfunction that occurs in diabetic patients independent of a recognized cause, such as coronary artery disease or hypertension. When you look at the epidemiology of diabetes and heart failure, the Framingham study actually firmly established the epidemiological link between diabetes and heart failure. The Framingham study is one of the largest studies, and which is currently ongoing. I think they're the 4th generation, which is basically looking at, they were studying a cohort of people found in Framingham. And what they found is that the risk of heart failure was increased more than 2-fold in men and 5-fold in women. So surprisingly, women who have got diabetes have a higher risk of developing heart failure as compared to men. And the diabetes predicted heart failure independent of coexisting hypertension or coronary artery disease. So excluding prior coronary or rheumatic heart disease, the relative risk of heart failure remained elevated at 3.8 in diabetic men and 5.5 in diabetic women. So again, it was still higher in women. Now, Bertone et al. Demonstrated in a national sample of Medicare claims of 150,000 patients with diabetes who are more than 65 years of age from 1949 to 1999, but the prevalence of heart failure was 22.3% at the start in 1994, with a subsequent incidence, that's newly diagnosed heart failure of 12.6% per year. So these patients with diabetes are at a very high risk of developing heart failure. Now, if you look at it, mortality improvement has been seen in major cardiovascular disease and atherosclerosis in diabetic patients, but not in heart failure or arrhythmia, as is shown in this slide. You can see that there's no difference in terms of heart failure or arrhythmia across the two groups. So a multifactorial approach is needed to tackle cardiovascular disease in patients with diabetes. And this was where now the Steno-2 trial was published in 2008 in the New England Journal of Medicine. And what it showed was that intensive therapy, where we had several treatment goals of just not being glucocentric. We're looking at the HbA1c, we're looking at the dyslipidemia, we're looking at blood pressure and smoking cessation, actually reduced your risk of death by 46%. In a 21 years follow-up, there was a 7.9 years of gain of life as well. So we need to look at, in totality, at somebody who's diabetic to actually reduce the cardiovascular risk. Now, patients with diabetes are also at a very high risk of kidney disease. As I mentioned earlier on, a lot of our patients in our dialysis units are actually diabetic. And diabetes remains the most common reason for progression to end-stage renal disease in many parts of the world. Diabetic kidney disease is a strong predictor of mortality in patients with diabetes, as I will show in the coming slides. And diabetic kidney disease occurs as a consequence of multiple pathogenic pathways in the diabetic kidney. And we all know that hyperglycemia plays a major but not exclusive role. There's an aspect of inflammation that occurs, which also contributes to the diabetic kidney disease. Up to 40% of patients who are diabetic will eventually suffer from kidney failure. And it's a huge number. This slide was shown by Dr. Twahir, so I'll not go through it in detail, but this is basically the structure of the glomerulus, showing the classical lesions. I mean, it basically starts off with minimal mesangial expansion, and then subsequently you tend to get the diffuse mesangial expansion and nodular glomerular, nodular sclerosis, or the Kimmel-Stell-Wilson lesions, which Dr. Twahir showed. But remember that the diabetes does not only affect the glomerulus, it also affects the interstitium as well. So these are the definitions of kidney disease. We have the chronic kidney disease, which is basically abnormalities of kidney structure or function. So it's not only the function we're looking at, we're also looking at the structure. So if somebody has polycystic kidney disease, he or she is classified as having chronic kidney disease, even though the creatinine will be normal. Diabetic kidney disease refers to kidney disease that is specific to diabetes, based primarily on the presence of elevated albumin in urine. And diabetic nephropathy is damage to the kidneys caused by diabetes, and is mainly diagnosed using a kidney biopsy. The terms diabetic kidney disease and diabetic nephropathy are often used interchangeably, but both ultimately lead to chronic kidney disease. Now, albuminuria is a key marker of kidney damage. And if you look at the current classification of chronic kidney disease, albuminuria has been incorporated in the definition of chronic kidney disease. And what albuminuria indicates is increased glomerular permeability. And we had the old classification of albuminuria, which was normal, microalbuminuria, and macroalbuminuria. But now, as Dr. Twahir alluded to, we have actually got the new nomenclature. It is normal to mildly increased, moderately increased, and severely increased albuminuria. And these are the values that have been given. And what this slide shows is that diabetic kidney disease is very common. So all diabetic kidney disease has been shown to be increasing. This is a study from the United States over periods of 5 years. And it shows that all diabetic kidney disease, persistent albuminuria, impaired eGFR, and both albuminuria and impaired eGFR has been shown to be progressively increasing across the years. So there was an 18% prevalence increase and a 34% prevalence increase from 1988 to 2005. So the proportion of diabetic patients with kidney disease has increased. In 1996, it was reported to be only 2.7% of the diabetic patients who had kidney disease, but now we are seeing cases of up to 13.8% of patients with diabetes and kidney disease in those with diabetes. Now, unfortunately, a lot of times we tend to diagnose our diabetics quite late, and this was as evidenced by the UK PDS, which showed that on average, a type 2 diabetic patient is diagnosed to be diabetic 10 years after the onset of diabetes. By that time, significant damage has occurred. And from this slide, we can see that the late onset of diabetes accelerates the occurrence of diabetic kidney disease. And you can see that the graphs actually, the curves actually separate quite early. Now, we have seen that there's been quite a significant reduction in terms of the cardiovascular outcomes in diabetes, but not the renal outcomes. So you can see that there's been a significant reduction in terms of your myocardial infarction, in terms of your stroke. But for end-stage kidney disease, the line has practically remained the same. It has just flattened out. The prevalence of diabetic kidney disease is projected to increase even further, and this is basically from 12 European countries. Now, irrespective of the stage, whether it is stage 3, 4, or 5, it is projected that by 2025, there will be a significant increase in all the stages of diabetic kidney disease. Now, why is diabetic kidney disease so important? Because it has got serious consequences. The markers of diabetic kidney disease, which are basically your declining estimated GFR and worsening albuminuria, they are associated with increased mortality, associated with increased renal events with the patient progressing on to end-stage kidney disease. They are associated with cardiovascular events like myocardial infarctions, strokes. They're associated with cardiovascular death as well, and impaired cognition. So this is why it's important to diagnose the patients with diabetes early, to diagnose that these patients have diabetic kidney disease, and to try and slow the progression of diabetic kidney disease. Now, mortality is more frequent in type 2 diabetic patients with kidney disease than in those without. Dr. Twairi had shown this slide, but I'll just briefly go through it again. Patients with no kidney disease basically had got a 4.1% 10-year cumulative incidence of mortality. It went up significantly to 17.8% in those with albuminuria, went up even more with impaired GFR to almost 25%. And when you combined albuminuria and impaired GFR, which is diabetic kidney disease, the markers of diabetic kidney disease, it was up to almost 50% mortality. So you can see that the mortality significantly goes up when you get diabetic kidney disease. So what's the approach to the management in terms of the drug choice in this new era? So there are several questions that we need to ask ourselves. One is that what is the patient-specific HbA1c target or the glycated hemoglobin target? Remember that most of the studies actually looked at targets of either less than 7% or less than 6.5%. By the time we're getting our patients coming to see us, on average, most of them have an HbA1c target of 9% or higher. So we need to understand by how much does each individual drug reduce your HbA1c target. The second question that we need to ask ourselves is, what is the best individual therapy taking the comorbidities and patient characteristics into consideration? Remember that a lot of our patients have got chronic kidney disease. There are a lot of drugs that we cannot use in the later stages of chronic kidney disease, like stage 4 and 5. Patient characteristics is very important because we cannot, it's not one size fits all. Different patients have different approach. I mean, they will react differently to different treatments as well. Some patients just don't want to hear the word insulin. Some patients don't want to take certain drugs because they feel that it's going to cause weight gain. Some patients are obese. Some patients are not so motivated as well. So if you become aggressive, they'll go into hypoglycemia. So we need to individualize each patient. The third question that is important that we need to ask ourselves is, which priorities are key? Is cardiovascular disease risk reduction key? Is renal protective effect key? Weight loss? What about hypoglycemia? Because remember that once the patient gets hypoglycemia, then they will stop taking the medication, then they'll stop listening to you as well. What about the cost? We live in sub-Saharan Africa, where cost is always an issue with our patients. Yes, we have all the drugs that have now been shown to cause a lot of good benefits, but can our patients afford them? And when you start on them, can the patients continue taking them? And which drug class is the best evidence for safety and long-term efficacy? So these are the important questions that we need to ask ourselves. And even the ADA and the ESD Consensus 2018, the rationale for therapy actually looked at these 4 aspects. Basically, they looked at the atherosclerotic cardiovascular disease reduction of heart failure and chronic kidney disease, the drug that minimize hypoglycemia, and they also looked at the cost of the drug, that it's a major issue or not, because you always have to look at that. Can the patients continue taking the drugs? Because you can't just ask the patient to take a drug for 2 months and then for the remaining 10 months, because the insurance is run out, the patient can't afford any other drug. So we look at the new kids on the block, which are the SGLT2 inhibitors. So what's the mechanism of the SGLT2 inhibitors? So if you compare the SGLT2, I mean the sodium glucose co-transporters, there are 2 types of SGLTs. There's the SGLT1 and the SGLT2. The SGLT1 is mostly found in the intestine, with around 10% being found in the kidney. The SGLT2, 99% is found in the kidney, so it's almost exclusively found in the kidney. If you look at the sugar specificity, SGLT1 can transport glucose or galactose, while SGLT2 is exclusive to glucose. Affinity for glucose is higher for SGLT1, while lower for SGLT2, but the capacity for glucose transport is much higher for SGLT2 than for SGLT1. The main role of SGLT1 is for dietary glucose absorption, and the main role of SGLT2 is for renal glucose absorption. So normally we filter around 180 grams of glucose per day, and virtually all of the filtered glucose is reabsorbed in the proximal tubules through SGLT2, that's almost 90%, and SGLT1 accounting for 10% in the S3 segment of the proximal convoluted tubule. Now, in diabetic patients, the renal glucose reabsorption is basically impaired because the filtered glucose actually exceeds the renal threshold of 11 millimoles per liter. And the capacity of transporters is also exceeded as well, resulting in urinary glucose excretion. So the SGLT2 inhibitors basically work in the proximal convoluted tubule, so they have to be filtered out. And this is the reason why we cannot use them in very low estimated GFRs. So the SGLT2 inhibitors reduce glucose reabsorption in the proximal tubule, leading to urinary glucose excretion and subsequent osmotic diuresis as well. So it also leads to a diuretic effect. Now, so as I mentioned earlier on, SGLT2 is mainly expressed in the kidney, SGLT1 mainly in the ileum, but it can also be found in the colon as well, in the heart and left ventricle. And there's some that is also found in the proximal convoluted tubule in a small degree. Now, these are the three different SGLT2 inhibitors. We have the empagliflozin, dapagliflozin, and canagliflozin. These are the various dosages we have. We start off with 10 milligrams for empagliflozin. We can use 5 or 10 milligrams for dapagliflozin and 100 to 300 milligrams for canagliflozin. Administration is only canagliflozin that has to be taken on an empty stomach. That's before the first meal of the day. The good thing with EMPA and DAPA is that you don't need to take it with or with, there's no specific timing for EMPA or DAPA. The peak plasma concentrations is quite rapid. It's between 1 to 2 hours for all the drugs. And their mean oral bioavailability is highest for dapagliflozin, 78%. So that means that DAPA would be a bit more effective than the other two drugs. They don't have any active metabolites, and these are the elimination half-lives. The selectivity is highest basically for EMPA, followed by DAPA, and then canagliflozin. So what is the clinical trial data that we have for SGLT2 inhibitors, and why are they considered to be now the golden kids on the block? So this was the DAPA CKD trial, which has just recently been published in the New England Journal of Medicine. And this was looking at dapagliflozin in patients with established chronic kidney disease. This was a randomized, double-blinded, placebo-controlled trial. It was conducted at 386 sites in 21 countries from 2nd of February 2017 all the way through to June 12th, 2020. That was supposed to be the estimated date of completion. However, the study was terminated early in March because of the fact that the independent adjudicators actually saw that it had got significant beneficial effects. So they recommended for the study to be terminated early in March. And it included adults with or without type 2 diabetics. Remember now, this is the very first study that has published results for chronic kidney disease, and it also included patients without diabetes as well. And these patients had an EGFR of 25 to 75 mils per minute. So remember what Dr. Twahi said earlier, initially when the other trials were published and the literature was reviewed, we were actually told that we shouldn't use these drugs in EGFRs of less than 45. And then subsequently it has come down to 30. Now we're actually seeing that we can use dapagliflozin in patients with an EGFR of up to 25 mils per minute. The other trials that are coming up, which actually have used 20 mils per minute as the cutoff. And the other eligibility criteria was a urine albumin creatinine ratio of between 200 to 5,000. And these are the patients who are eligible for participation. So they had more than 7,000 patients who were screened. 4,304 participants underwent randomization. There were 2,152 in each arm. So the primary composite endpoint for the DAPA CKD trial was the first occurrence of any of the following: a decline of at least 50% in the estimated GFR, the onset of end-stage kidney disease, and death from renal or cardiovascular causes. So you can see the primary endpoint was purely renal. The secondary outcomes included the composite kidney outcome of a sustained decline in the EGFR of at least 50%, end-stage kidney disease or death from renal cause, or the composite cardiovascular outcome defined as hospitalization from heart failure or death from cardiovascular cause, or death from any cause. So these are the baseline characteristics of patients. You can see that most of the patients were age 60 years. Most of the patients were males, okay? Majority of the patients were white. We had significant Asian population in this study. If you look at the EGFRs, majority of the patients, almost 75% of the patients basically were in stage 3 kidney disease, 3A and 3B, which is quite significant as well. And the other important thing is that 10% of these patients actually had pre-existing heart failure as well. These were the primary outcomes. So the primary composite outcome, there was a significant reduction in the primary composite outcome, which was statistically significant with a p-value of less than 0.001. And if you look at the secondary outcomes, all of them are statistically significant. The composite of decline in estimated GFR of more than 50%, end-stage kidney disease, or death from renal causes. There was a statistically significant reduction in those endpoints. If you look at the any serious adverse events, actually the serious adverse events actually occurred in a placebo as compared to the dapagliflozin arm. The risk of amputations, because remember that the other trials, like the CANVAS trial, showed that canagliflozin had an increased risk of 2 amputations, but the risk of amputations was much lower in the, it was lower in the dapagliflozin arm. And none of the adverse effects were actually statistically significant per se. So here are the Kaplan-Meier curves. Looking at the primary composite outcome, you can see that the curves started separating quite early, and it showed that there was a 39% risk reduction in the primary composite endpoints. The renal specific composite endpoints, again, there was a 44% risk reduction in the dapagliflozin arm. The composite from cardiovascular causes or hospitalization from heart failure, there was a 29% risk reduction in the dapagliflozin arm. And again, death from any causes as well, there was a 31% risk reduction that was all statistically significant when using the dapagliflozin as compared to the placebo. This was a forest plot, and again, in all the subsets of the patients whom they analyzed, it actually favored the dapagliflozin to be a better, to have a better outcome as compared to the placebo. Now, if you look at the estimated GFR, basically you see that initially there is a decline in the GFR, but this is expected because of the diuretic effect. But subsequently, over time, what happens is the kidney function basically stabilizes over time. And again, this beccomes very important, because what a lot of us tend to do is that we tend to get scared when you get a slight drop in your estimated GFR or a rise in creatinine, and you want to stop all these beneficial drugs. So we have to individualize each patient so that we don't stop these beneficial drugs. So the conclusion for this trial, the DAPA-CKD trial, was that among patients with chronic kidney disease, regardless of the presence or absence of diabetes, the risk of a composite of a sustained decline in the estimated GFR of at least 50%, or reaching end-stage kidney disease, or death from renal or cardiovascular causes was significantly lower with the dapagliflozin than with the placebo. So this shows that the dapagliflozin had quite beneficial effects in patients with chronic kidney disease. And this is irrespective of whether they were diabetic or not. Almost a third of the patients were not diabetic. The other trial that actually looked at this cardiovascular disease was EMPA-REG outcome trial. This is among the first trial that was published. It was looking at empagliflozin and cardiovascular outcomes and mortality in type 2 diabetics. So this trial looked only at type 2 diabetic patients. And it was a randomized double-blinded placebo-controlled trial to assess the effects of once-daily empagliflozin versus placebo on cardiovascular events in adults with type 2 diabetics who are at high risk of cardiovascular disease against a background of standard care. So these are already high-risk patients who already had possibly established cardiovascular disease. And this was at 590 sites in 42 countries. This was how it was. The patients were randomized to either placebo, EMPA-10, or EMPA-25 milligrams. And this was the outcome. I think Dr. Tawhid might have shown the slide. There was a 14% reduction in the 3-point measured was cardiovascular events, a 38% reduction in cardiovascular death, 32% reduction in all-cause mortality, and a 35% reduction in heart failure hospitalization. The CANVAS program was basically consisting of 2 sister trials of canagliflozin, and they had 10,142 patients in total, 4,330 in the first trial and 5,812 in the second trial. And they had a 2-week placebo run-in, and the patients were randomized to 300 milligrams of canagliflozin or 100 milligrams of canagliflozin versus a placebo. And what they found was that there was a significant reduction in the 3-point MACE by 24% in the canagliflozin arm as compared to the placebo arm. And the 3-point MACE is your cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. If you look at the summary, the primary cardiovascular outcome, the composite, the 3-point MACE, there was a reduction, but the individual outcomes were actually not statistically significant because they crossed the line. The hospitalization for heart failure was significant as well, but the all-cause mortality was not significant because it actually crossed the line as well. Then there was the issue of the increased amputation. This is one of the adverse effects, and it was statistically significant as compared to placebo in the CANVAS program. The DECLARE TIMI58 was a multinational randomized placebo-controlled phase 3b cardiovascular outcome trial, and it looked at more than 17,000 patients with type 2 diabetes and who actually had cardiovascular disease or were at high risk of cardiovascular disease. And they were assigned to either dapagliflozin 10 milligrams once daily or a placebo. And they had all the other glucose lowering agents as per the treating physician. And it was an event-driven trial. The median follow-up was for 4.2 years. The primary safety endpoints was a composite of cardiovascular death, non-fatal MI or non-fatal ischemic stroke, the 3-point MACE. And the primary efficacy endpoints were the MACE, the composite of hospitalization for heart failure or cardiovascular death. They also had the secondary endpoints, which are the renal endpoint, the renal composite endpoint of a sustained 40% decrease in eGFR to an eGFR of less than 60 mils per minute, and or the patients reaching end-stage kidney disease and or renal or cardiovascular death. And the secondary endpoint was all-cause mortality. They also had additional safety endpoints. They looked at amputations, fractures, DKA events, liver events, and malignancies. And these are the cardiovascular risk categories. So patients who either had established atherosclerotic cardiovascular disease. So it was just like in the EMPA-REG trial, but then the DECLARE TIMI58 actually also looked at those patients who are at high risk as well. So not only established cardiovascular disease, but patients who are at high risk of developing cardiovascular disease. So that was the main difference. There was non-inferiority, but no superiority that was demonstrated for the composite of the non-fatal MI, non-fatal stroke, or cardiovascular death. But you can see that the curves are starting to separate, and although it did not reach statistical significance. However, if you look at cardiovascular death or hospitalization for heart failure, the secondary endpoint, there was a significant reduction, a 17% reduction, and this was statistically significant. Even the renal composite endpoints, there was a 24% reduction in the renal composite endpoints as compared to the placebo within the dapagliflozin arm. So these drugs had been shown to actually reduce the risk of heart failure and the renal composite endpoints. How about the dapagliflozin in patients with heart failure? So this was a Dapper heart failure trial, and this was published last year in September. And this was basically because of the DECLARE TIMI58, so which actually showed that the Dapper was shown to reduce the risk of hospitalization for heart failure compared with placebo in patients with type 2 diabetes. And this was irrespective of the presence of heart failure history, because only 10% of the patients in the DECLARE TIMI58 had a heart failure history. So based on the current available data, they postulated that the cardiovascular protective mechanisms of the SGLT2 inhibitors were believed to be independent of the glycemic control in patients with type 2 diabetes and may be applicable to both patients with or without type 2 diabetics. So the Dapper heart failure is the first heart failure outcome study to report results with an SGLT2 inhibitor, that is dapagliflozin, in addition to standard care of treatment for the treatment of heart failure with reduced ejection fraction in patients with or without type 2 diabetes. So they included almost a third of the patients, again, had no diabetes in this trial, the Dapper heart failure trial. So they had more than 4,700 patients who are more than 18 years of age with or without type 2 diabetes, and they were diagnosed to be having symptomatic heart failure with reduced ejection fraction, New York Heart Association class 2 to 4. And the left ventricular ejection fraction had to be less than 40% in the last 12 months with an elevated pro-BNP. And in eGFR, the cutoff was 30 mils per minute. And they were randomized to the dapagliflozin 10 milligrams plus standard of care or placebo plus standard of care. And the primary endpoint was the time to first occurrence of any of the components death, cardiovascular death, or a hospitalization for heart failure, or an urgent heart failure visit. And these are the secondary endpoints: time to first occurrence of either the components of the composite, which is cardiovascular death or hospitalization for heart failure, total number of hospitalization for heart failure and cardiovascular death, change from baseline measured at 8 months in the total symptom score of the KCCQ, which is the cancer scoring system that they use for symptoms of heart failure, and the time to occurrence of any of the components of the composite, more than 50% sustained decline in eGFR or reaching end-stage renal disease or renal death, or time to death from any cause. And what they found was that there was a significant reduction in terms of your primary endpoint, which was cardiovascular death, or hospitalization for heart failure, or urgent emergency department visit for heart failure, by almost 26%. And the number needed to treat was 21. And this was all statistically significant, as you can see the p-value. The composite of the primary endpoint, which was a worsening of the heart failure event, there was a 30% relative risk reduction in the Dapper arm as compared to the placebo arm. The component of the primary endpoint, that was cardiovascular death, again, there was an 18% relative risk reduction in the Dapper arm as compared to the placebo arm, and it was statistically significant. So this shows that in patients with or without type 2 diabetes and who have heart failure, we can actually use the dapagliflozin to actually reduce the risk of hospitalization for heart failure or emergency visits for heart failure or cardiovascular death. Then there was this other trial that actually looked at canagliflozin and renal outcomes in type 2 diabetes and nephropathy. This was a double-blinded randomized trial that looked at type 2 diabetic patients with albuminuric chronic kidney disease. All patients had an eGFR of between 30 to less than 90 mils per minute, and they were randomized to canagliflozin at a dose of 100 milligrams per day or placebo. And the primary outcome was a composite of end-stage kidney disease. Either the patients were on dialysis or were on the transplant waiting list, or a sustained eGFR of less than 15 mils per minute, or the doubling of serum creatinine, or death from renal or cardiovascular causes. So the trial was stopped early. There had more than 4,400 patients had been randomized. The median follow-up, unfortunately, was only 2.62 years. And what they found was that the relative risk of the primary outcome was 30% lower in the canagliflozin group than in the placebo group. And in this trial, as opposed to the CANVAS trial, there was no significant difference in the rates of amputation or fractures between the placebo group and the canagliflozin group. So why are SGLT2 inhibitors cardioprotective and nephroprotective? So it has been thought that apart from the glucose lowering effect, which is here, they also reduce your albuminuria. They also reduce uric acid. Remember what the slide that Dr. Tahir showed about the effects of uric acid and the fact that it can progress chronic kidney disease and it can progress your heart failure. They also reduce your arterial, your blood pressures and your arterial stiffness. They do have a reduction in your sympathetic nervous system activity, reduce weight and reduce your visceral adiposity. They also tend to reduce your oxidative stress as well. Now, how about the tubular glomerular feedback with SGLT2 inhibitors, which is postulated to be the renoprotective effect of the SGLT2 inhibitors? Normally what happens is that in the proximal convoluted tubule, we tend to be, the sodium and glucose is reabsorbed using the SGLT2 co-transporters. So what happens is there's reduced sodium and chloride that basically reaches the thick ascending limb of the loop of Henle. Now, when that happens, this basically cuts off the release of adenosine, and adenosine is basically a potent vasoconstrictor, and this leads to afferent arteriolar vasodilatation. So when you get afferent arteriolar vasodilatation and your efferent remains the same, this basically increases your glomerular pressures, and it leads to intraglomerular hypertension, which is what is a hallmark of which leads to hyperfiltration, which is a hallmark in early stages of diabetic nephropathy. So when you use an SGLT2 inhibitor, you basically inhibit the absorption of sodium and glucose. So there's more sodium and more chloride that is available, and it basically comes all the way to the thick ascending limb of the loop of Henle at the juxtaglomerular, the macula densa cells. And because of the fact that there's more sodium that is being released, it basically leads to increased production of adenosine from the macula densa cell. And this adenosine leads to afferent arteriolar constriction. And this basically protects the glomerulus. It leads to a reduction in the intraglomerular pressures. And this is how the SGLT2 inhibition reduces the hyperfiltration via the tubular glomerular feedback. So these are the advantages of the SGLT2 inhibitors. They have cardiovascular risk reduction, as we have shown. They are renoprotective. They reduce heart failure progression. They have durable glucose lowering at all stages of disease. And they can be combined with a wide range of oral glucose lowering drugs. And they can also be combined with insulin. They contribute to weight loss. They also contribute to blood pressure lowering. And they have a very low risk of hypoglycemia. But we have to be careful. We cannot use SGLT2 inhibitors with type 1 diabetic patients. We cannot use SGLT2 inhibitors in type 2 diabetic patients who are prone to ketosis as well, because they can cause diabetic ketoacidosis or euglycemic ketoacidosis. So in summary, diabetes is a significant risk factor for cardiovascular and kidney disease, as we have shown. And a multifactorial intervention is key to long-term cardiovascular risk reduction, as was shown by the Steno-2 trial. We just shouldn't be looking at reducing the glucose. We need to look at the other factors as well, like your lipid lowering, cessation of smoking as well. We need to control the blood pressures as well. The choice of therapy can now be tailored in patients with type 2 diabetes with a significant cardiovascular risk to improve clinical outcomes and the reduction in albuminuria and decline in your eGFR. The new kids on the block, the SGLT2 inhibitors, are an efficacious and beneficial add-on therapy choice to metformin and various insulin regimens with a very good safety profile. And SGLT2 inhibitors have been shown to be beneficial in high-risk patients who are not having diabetes, as was evidenced by the Dapper CKD and the Dapper heart failure trial. And correct patient profiling is key to ensure that the patients derive maximum benefits of this drug class. So I'll stop there and I'll hand over to you, Dr. Joyce.
Thank you so much, Dr. Bagha, for that very concise discussion about profiling of patients who have diabetes, heart failure, and chronic kidney disease. Thank you so much. There's a patient who has a question for you. He asks whether there's any experience with SGLT2 inhibitors used in post-transplant patients with new onset diabetes after transplantation or diabetes in a post-transplant patient.
Actually, there's no data for post-transplant patients. So you just have to individualize the patient and see. Although there should be no contraindication per se, but the only thing that you have to be make sure is that the patients don't get dehydrated, because these drugs tend to have a diuretic effect as well. I don't know if Dr. Twahir has anything to add.
No, I quite agree with you. I think one just needs to start using them when the indication arises, and we wait and see. You'll be a pioneer.
All right. Thank you. Thank you. Any other questions from the attendees? Any comments? Shall I give some time for any comments?
Probably we can.
A question, or just his experience in the sense that the trial that you discussed about the use of Abixostat in patients who are high risk, who have got high risk cardiovascular, who are at high risk for cardiovascular disease, and they say that Abixostat increased the risk. We have seen patients who basically develop Stevens-Johnson syndrome with allopurinol. So I don't know what your take is on that.
Good question, and that's why I said I was very excited with using Febuxostat to lower my uric acid, because I'd never seen any side effect profile. But now, with increased data showing that Febuxostat has increased cardiovascular risk, then again, I'm at a crossroad and I'm waiting for more guidance, and I'm hoping that drugs like Rasburicase will come out to bail me out, as because I still strongly feel that uric acid is a risk factor and we need to find ways of reducing it. But so far, the drugs have not kind of helped that much. Yeah. Dr. Yazid from South Africa wants to know whether you are worried about UTIs in patients post-transplant if you give them SGLT2, since these drugs cause a lot of,
Actually, the urinary tract infection is one of the side effects of the SGLT2 inhibitors, and this is why I say that you need to individualize each patient. So if you feel that the benefit outweighs the risk, then you need to use the drug. Then basically, what I would suggest is that you advise the patient that they need to be monitoring for any symptoms or signs of an infection. And should they get any signs or, any symptoms of a urinary tract infection, they should stop the drug immediately and come to the hospital because they're on heavy immunosuppressants. But normally, as I said, that there's no data per se in terms of post-transplant diabetes or new onset diabetes after transplant, or even patients with pre-existing diabetes have been transplanted. But if the patient was already on the drug and we transplant them, then basically we leave them on the drug, but we tend to monitor more closely for the urinary tract infections.
Thank you. There's one more question. Sorry. There's one more question from, sorry, I'm unable to open this. From Laura Curry. Why do you think they, I think this was basically for you, Dr. Bagha, about the Dapper, glyphosine, and EMPA. Why do you think they have suddenly become the new kids on the block? Is it that the big trials have come out more recently? And her feeling is that they have been around for a while.
Actually, if you look at it, the first drug actually to be launched in Kenya was the Dapper glyphosine, and if I remember correctly, it was in 2016. And the EMPA trial was published, if I'm not wrong, in 2014 or 2015, and that was the first large trial. But before that, there have been several smaller trials that were showing the benefits. And of course, once when these large trials came out and they were showing significant cardiovascular disease risk reduction and reduction in your hard endpoints of renal disease, like progression to end-stage kidney disease, people became quite excited. Because as Dr. Twahid puts it, we have been looking at the very soft endpoints, especially for kidney disease and renal outcomes like microalbuminuria. And this is why now, when we get these hard endpoints like doubling of your serum creatinine or reaching end-stage kidney disease, and we find that these drugs actually significantly reduce those hard endpoints, then all of us tend to get excited and we want the best for our patients. And this is why they become quite a big success. And this is why even the FDA, I think from 2012 or 2010, insisted that any new drug that comes into the market, you have to show the reduction in the measured cardiovascular endpoints, the MACE. And if you look now from 2010 onwards, almost all the trials are mentioning MACE as one of as the primary outcome. So these these trials for MACE actually take 5 years on average. And this is why now from 2015 onwards, when all these trials are being publishing their data and the results, we're all getting excited. And this is why the SGLT2 has become quite a hit right now.